Good day, everyone. We are Group 4, and today we will be talking about medically significant bacterial disease, specifically diseases caused by Streptococcus pneumoniae. We will talk about the following: characteristics of this bacteria, its mode of transmission, epidemiology, infections associated, pathogenesis, immune responses of the host, and lastly is the prevention and treatment. First, let's define what are streptococci. Streptococci, a medically significant gram-positive bacteria, are non-motile, non-spore-forming, catalyst-negative, and most of these bacteria are facultatively anaerobic. It usually occurs in chains and pairs, and it requires a media with complex nutritional requirements like blood-enriched medium for its isolation. Now, how about Streptococcus pneumoniae? Streptococcus pneumoniae is a part of the normal microflora of the human upper respiratory tract. It is known as the pneumococcus due to its morphology and involvement in pneumococcal pneumonia. Streptococcus pneumoniae cells are gram-positive, lancet-shaped cocci that usually occur in pairs or diplococci but may also occur in singly and in short chains. It is an alpha hemolytic bacteria where when cultured on blood agar, it shows an incomplete and greenish hemolysis. Individual cells are between 0.5 and 1.25 micrometers in diameter. Like other streptococci, they lack catalase and ferment glucose to lactic acid. Its growth requires a source of catalase, which is supplied in blood agar to neutralize the large amount of hydrogen peroxide produced by the bacteria. Its mode of transmission. The transmission mode of S.pneuoniae can occur horizontally or vertically. Horizontal transmission can occur in four ways. First, inhalation and/or direct person-to-person contact via respiratory droplets, which is the most prevalent means of transmission observed in this organism. Second, indirect contact of contaminated inanimate objects, also known as fomites, attributed by the ability of the bacterium to form biofilms. Third, autoinoculation in persons carrying the bacteria in their upper respiratory tract. And fourth, co-infection with viruses that increase bacterial cell density and host colonization of S. pneumoniae by attaching to cells that are initially infected with the virus, hence enhancing transmission. In some cases, vertical transmission or the passage from mother to offspring during the period immediately before and after birth is also observed in S. pneumoniae infection. However, occurring at a low incidence rate for about 1% to 10%, but is related to high mortality and morbidity in neonatal periods. Moreover, S. pneumoniae is not part of the usual vaginal normal microflora, and the incidence of its colonization in pregnant women is exceptional, 0.03% to 0.75% of cases. Epidemiology. The World Health Organization bulletin in 2008 pointed out that the Philippines is one of the top 5 countries with the highest number of pneumonia cases associated with S. pneumoniae. This disease-causing agent frequently affects toddlers who are less than 2 years old with 6% mortality and an incidence rate of 12.13%. Adults with an age at least 65 years old linked with 6.12% mortality and an incidence rate of 30.83%. And immunocompromised individuals or those with chronic disease including cancer, diabetes, functional asplenia, and sickle cell disease, resulting in invasive pneumococcal disease. Pneumococcal infection is a term used to refer to any infection caused by the bacteria of Streptococcus pneumoniae. Among the 92 serotypes of Streptococcus pneumoniae, many of it are known for being the cause of many serious diseases such as sinusitis, septic arthritis, osteomyelitis, peritonitis, and endocarditis. However, only a few serotypes are linked to majority of pneumococcal infections that can attack different parts of the body like the lungs, bloodstream, and brain. Here are the following predisposing factors of pneumococcal infections. Children aged 5 years old and below and adults older than 65 years are at more risk to develop pneumococcal infections. Among children, lack of breastfeeding, being exposed to cigarette smoke, and absence of proper immunization with pneumococcal conjugate vaccine are also the additional factors that may be associated with increased risk of pneumococcal infections. Medical conditions such as HIV infection, presence of a malignant tumor, diabetes mellitus, functional or anatomical asplenia. Functional asplenia is the condition where the spleen fails to perform its function because of diseased tissues or spontaneous infarction, while anatomic asplenia is the absence of spleen due to various reasons. For example, splenectomy and other infections or diseases that may weaken one's immune system are all associated with increased risk of pneumococcal infections. Aside from diseases that weakens the immune system, medical conditions that are related to decreased pulmonary clearance are also predisposing factors. Examples of such medical conditions are asthma, chronic bronchitis, and chronic obstructive pulmonary disease. Starting off with sinusitis. This is when fluid starts to build up in the air-filled sinuses, allowing Streptococcus pneumoniae to grow, resulting to inflammation or swelling of tissues that line the sinuses. Common symptoms include runny nose, stuffy nose, facial pain or pressure, headache, post-nasal drip, and sore throat. Several risk factors for sinusitis are previous colds, seasonal allergies, smoking, which also includes exposure to secondhand smoke, complications brought about by structure of the sinuses, for example, nasal polyps and weak immune system. In diagnosis of sinusitis, the physician inspects first for the presence of probable inflammation or tenderness of the nose and face, and by looking at the inside of the nose. Through this physical examination, a proper diagnosis can already be made. But when the case seems to be similar to other infections, other tests can be made to ensure a correct diagnosis. Imaging studies are essential methods to have vision of the inside of sinuses. Some examples are nasal endoscopy and CT scan. Collection of nasal and sinus samples for laboratory testing is not required in a diagnosis, but can be used only if the condition of the patient does not respond to the treatments administered and/or become worse. Septic arthritis, also known as infectious arthritis, occurs when Streptococcus pneumoniae spreads from one area of the body to another through the bloodstream. Septic arthritis is an infection where either the joint fluid or joint tissue is inflamed. Common joints that are affected are those present in the knees or hips. Main symptoms of septic arthritis are intense pain, swelling of joints, and fever. Other symptoms may also include such as chills, fatigue, and incapability to move joints and/or limbs with infected joints. This infection is common among young children and the elderly. Risk factors include systemic blood-borne infection, osteoarthritis, those who have history of septic arthritis, alcoholism, presence of lung or liver disorders, and weak immune system. It is important that septic arthritis is diagnosed early in order to inhibit as early as possible any possible permanent damage to the joints. Usually, the process begins with knowing the patient's medical history and conducting a physical exam. Other tests done to look for the presence of bacteria is through blood, phlegm, spinal fluid, and urine testing.
Similar to septic arthritis, endocarditis occurs when Streptococcus pneumoniae spreads through the bloodstream. The only difference is that the bacteria, which is from a specific part of the body, invades the heart muscles. Endocarditis is life-threatening, and it is an infection where the inner linings of the chambers and valves of the heart is inflamed. Symptoms of endocarditis may vary among individuals, depending on the health condition of a person, how long the infection has been present, history of heart problems, heart surgery, and also previous endocarditis. In addition, the symptoms may also change over time. Symptoms may be mild or severe, and the onset of it can be abrupt or develop slowly. Reasons behind these differences may be accounted to the previous medical conditions mentioned earlier. Some of the common signs and symptoms of endocarditis are pale skin, aching joints and muscles, chest pain during breathing, fatigue, flu-like symptoms, night sweats, heart murmur or the abnormal heart sound of turbulent blood flow through the heart, decreased appetite, and unintentional weight loss. Persons with faulty or damaged heart valves are more likely to develop endocarditis. It is uncommon among individuals with healthy hearts, but this doesn't mean that they cannot develop the said infections. Other risk factors include older age, having a congenital heart defect, having an artificial implanted heart device like pacemaker, using contaminated needles to inject drugs, poor dental health, and having a catheter for a long period of time. During the early stages of infection, symptoms of endocarditis usually appear similar to cases of flu and other infections, which is the reason why many cases of endocarditis are either misdiagnosed or remain undiagnosed. Before conducting any test, the physician will first examine the patient's symptoms and medical history. As mentioned, since symptoms may appear similar to other infections, the following test can be done to verify that the infection is indeed endocarditis. First is true blood test, where a blood culture test will be performed to confirm what microorganism causes the infection. Transthoracic echocardiogram, an imaging test utilizing ultrasound waves, can also be used to get a proper and actual view of the heart's valves. Usage of electrocardiogram can monitor the electrical activity of the heart and detect if there are any abnormalities in an individual's heart rate. Pneumococcal pneumonia is a kind of pneumonia where the bacteria infects the upper respiratory tract. It can be differentiated by other kinds of pneumonia because the bacteria infecting the lungs can invade the bloodstream and eventually spread to other parts of the body such as the middle ear or the nervous system, causing otitis media and meningitis respectively. General symptoms of pneumococcal pneumonia include sudden onset of fever and chills or rigor. Other clinical features include pleuritic chest pain, which is the sudden and intense pain in the chest during breathing, productive cough, wherein the cough produces mucopurulent discharge containing both mucus and pus, dyspnea or shortness of breath, tachypnea, which is rapid breathing, hypoxia, tachycardia, characterized by having a rapid heart rate, and malaise, a general feeling of discomfort or uneasiness. Pneumococcal pneumonia is common in adults aged 65 years or older, and also among children younger than 5 years old. Aside from age, individuals with heart, lung, or liver diseases, sickle cell anemia, HIV or AIDS, and any disease that weakens their immune system, and those who had organ transplants are at risk of acquiring pneumococcal pneumonia. Pneumococcal pneumonia can be diagnosed by starting with the physician, going over an individual's symptoms, and doing a physical exam. Further, a laboratory test can be conducted to determine what specific microorganism causes the infection. Some samples collected for a laboratory test are blood, saliva, and lung fluid. A chest X-ray can also be used to detect any abnormalities in the lungs. It is very important to diagnose pneumococcal pneumonia as early as possible, as well as what specific microorganism causes it, because the appropriate treatment may be varying. Bacteremia is an infection where a bacteria is present in the bloodstream of an individual. Bacteremia can occur unexpectedly to those who are using catheters, have tissue infections, and persons that underwent certain medical procedures involving the dental, genitourinary, or gastrointestinal tract. Many individuals with bacteremia are asymptomatic, meaning they do not show any symptoms at all. This is because in healthy people, bacteremia is usually cleared by their immune system before it can even cause any disease or infection. When there is development of symptoms like fever, chills, and shaking, it is a typical indication of a more serious condition like sepsis. Sepsis and bacteremia must not be interchangeably used because sepsis is another clinical condition. Though it also involves the blood, unlike bacteremia, it is characterized by organ dysfunction that is life-threatening caused by dysregulated response to infection and presence of range of symptoms like fever and chills as mentioned. Also, when bacteremia becomes untreated, it can lead to serious complications that may cause organ failure and worse, even death. Diagnosis of bacteremia is often done through culture of virus samples. Most typical test is using blood culture, where blood of the individual is tested to detect presence of bacteria. Moreover, imaging tests like X-ray, CT scan, or ultrasound can be used to find if there are probable infections in the body. Meningitis is an inflammation of the meninges, the three membranes that cover and protect the central nervous system, namely dura mater, arachnoid mater, and pia mater. Meningitis often occurs when the fluids surrounding the meninges are infected with bacteria or virus. But meningitis can also occur because of other reasons like cancer and drug allergies. There are people who are at increased risk of meningitis. Some are the following. First, age. Age is a crucial risk factor because newborns, babies, and young children are more susceptible for meningitis, specifically bacterial meningitis. But it is important to take note that people of any age can still develop meningitis, and for different age groups, varying bacteria or virus can cause meningitis. Another risk factor is occurrence of certain medical conditions, most especially on individuals with compromised immunity. For instance, people with HIV or AIDS and autoimmune diseases are more vulnerable to infections. More, those who are undergoing certain medications and had surgical procedures can also increase risk of having meningitis. Examples of these are individuals having chemotherapy and those that had their organ or bone marrow transplants. Third, the community to which one lives can also be a risk factor. Crowded, small places where large groups of people gather can be a venue to where meningitis can easily spread. Some of these places include boarding houses and dormitories, daycare centers, and barracks. In fact, there has been outbreaks of meningococcal diseases reported in college campuses, but of other bacteria causing it, Neisseria meningitis. Microbiologists working with meningitis-causing bacteria are also at risk for meningitis. The same goes with workers in the farm, and those with interaction with animals are at high risk of meningitis, being infected with the bacteria Listeria. Symptoms of meningitis can be varying depending whether it is caused by a bacteria or a virus and the age of a person. Typically, symptoms of bacterial meningitis are more severe than viral meningitis. Generally, symptoms of meningitis include abrupt onset of fever, headache, and stiff neck. Specifically, additional symptoms of bacterial meningitis can include altered mental status, nausea, vomiting, photophobia or the eyes being sensitive to light, appearance of purple areas in the skin which resembles bruises, and feeling lethargic. Since babies are at high risk of meningitis, and the symptoms mentioned can be either not shown or hard to observe on them, thus, the following symptoms are observed instead. Babies being inactive, irritable, vomit, feed poorly, abnormal reflexes, and bulging of fontanelles or the soft spots found in the baby's skulls. Incubation period of meningitis typically ranges from 3 to 7 days. It is important that meningitis be diagnosed and treated as early as possible because this can become more serious. In terms of symptoms, seizures and comatose may occur, and meningitis can further lead to other complications like sepsis causing organ failure, permanent disabilities, for example, brain damage, loss of hearing, and learning disabilities, and worse, death in as little as few hours if remained untreated. But still, many people recover from meningitis with proper diagnosis and treatment. Diagnosis of meningitis begin with examining one's medical history and knowing necessary information like age and community to which the individual lives. Doing a physical exam is also a part of the first steps in diagnosis, and the physician tries to observe if there is fever, increased heart rate, stiff neck, and reduced consciousness. A test called lumbar puncture or spinal tap is ordered by the physician to look for any increased pressure in the central nervous system and also to locate any probable inflammation and/or presence of bacteria within the spinal fluid. In addition, by doing lumbar puncture, the physician will be able to determine which treatment is best to be administered. Other common tests in diagnosing meningitis are the following: blood culture, which allows to detect presence of bacteria in the bloodstream because it might also invade the central nervous system. By having a CBC or complete blood count, having a high number of white blood cells might be an indication of meningitis because basically, white blood cells fight the infection. Imaging tests like chest X-ray and CT scan can also be used. Chest X-rays can show if the individual has pneumonia. This result is essential because typically, pneumonia precedes meningitis. For CT scan of the head, brain abscess or sinusitis can be revealed, and from the sinus, the bacteria can spread to the meninges, causing meningitis. Also called as middle ear infection, it occurs when the air-filled area behind the eardrum becomes inflamed. There are two types of otitis media: acute otitis media or AOM, and otitis media with effusion or OME. Acute otitis media is a type of ear infection that is accompanied with swelling and redness around the eardrum, which is a result of mucus and/or fluid building up in the middle ear. Otitis media with effusion, on the other hand, occurs when after the infection goes away, the mucus and/or fluid still continues to build up. This actually causes the feeling of the ear being full. There can be varying symptoms of otitis media depending on the age of an individual, but the onset of these symptoms is typically rapid. Among children, the common symptoms include ear pain, have trouble sleeping, fuzziness, trouble of hearing clearly, loss of balance, fever, discharge of yellow, clear, or bloody fluid from the ear, headache, and loss of appetite. In adults, common symptoms are ear pain, discharge of yellow, clear, or bloody fluid from the ear, and trouble of hearing clearly. Children are more susceptible to otitis media than adults. Moreover, the following are the risk factors for otitis media: prematurity and low birth weight, family history, absence of breastfeeding, craniofacial abnormalities, neuromuscular diseases, crowded community living, exposure to tobacco and pollution, and season, specifically during fall or winter. Diagnosis of otitis media often starts with looking into the medical history of an individual and by doing a physical examination. During the physical examination, an otoscope is used to check for any redness, swelling, pus, and fluid in the outer ear and eardrum. A test called tympanometry can also be conducted to determine if the middle ear works properly. The physician uses a tympanometer, a device which will be put inside the ear canal, after which pressure is altered in order to make the eardrums vibrate, and the vibrations produced will be graphed. This will then be interpreted by the physician.
Now let's go to its pathogenesis. Children have a high likelihood of being a carrier for a longer time and decrease as they get older. There are over 90 different serotypes of S. pneumococci. Pneumococci type 6, 14, 19, and 23 frequently cause pneumococcal infection in children, while types 1 to 8 primarily cause pneumococcal pneumonia and bacteremia in adults. Though it has not been established on humans, the infectious dose of S. pneumococci is about 104 bacteria for invasion of the blood-brain barrier and 107 to 108 bacteria for bacterial sepsis and pneumonia respectively. The main determinant of the pneumococcal virulence is the polysaccharide capsule, which protects the pathogen from phagocytosis. It is composed of teichoic acid and the peptidoglycan with a typical ribitol phosphate backbone covalently linked to phosphorylcholine, which binds proteins to bacterial surfaces. Pilus, another surface structure, facilitates adhesion and aid in colonization and inflammation. Key enzymes that contribute to the pneumococcal virulence include autolysine, which hydrolyzes the peptidoglycan leading to cell wall lysis and inflammation, and the pneumococcal surface protein A, which acts by disrupting the complement induction preventing opsonization and phagocytosis. Additionally, the choline-binding proteins or CBP A, D, E, and G function for bacterial adhesion. CBP-A is responsible for bacterial translocation by binding to the polymeric immunoglobulin receptor in the nasopharyngeal mucosa. Another integral virulence factor is the pneumolysine, which damages the alveolar epithelium directly, introducing the bacteria to the blood and an IgA1 protease. On the other hand, hyaluronidase enzyme facilitates proliferation through tissue invasion by hydrolysis of extracellular matrix components. Hyaluronate lyase in particular enhances tissue permeability associated with wound infection, pneumonia, bacteremia, and meningitis. S.pneumococci are divided into two types defined by their surfaces: transparent and opaque variants. Transparent variants with less capsule and PSPA but greater CBPA and autolysine A predominate the nasopharynx. In the opaque variants, greater capsule and PSPA with less CBPA on the blood with the increased ability for biofilm formation and invasion of the lungs and the brain. Inhabited multiplication of the S.pneumococci results in cell lysis, releasing cell debris and pneumolysine mediated by the autolysine. Consequently, this triggers the induction of inflammatory responses directly through complement activation and anaphylatoxin formation and indirectly through phagocyte recruitment and activation. Now we proceed to the host immune responses. The immunobiology of S.pneumoniae involves elaborately both the innate and adaptive immune system response. Before delving deeper, it is essential to recall that innate immunity involves a non-specific response, hence, the action is immediate. Cell-related innate immune responses against pneumococcal infection include: first, the epithelial cells, which involve multiple types such as that provide a protective barriers as they line tissues and organs in the respiratory tract system, produce and release chemokines and cytokines to recruit other cells, kill pneumococcus by secreting antimicrobial peptides. Specialized epithelial cells called goblet cells secrete mucus necessary for trapping foreign particles and pathogens, and ciliated epithelial cells which promote mucociliary clearance or expelling of pathogens with mucus by inducing sneezing or coughing. Second, phagocytic cells including neutrophils and macrophages. Neutrophils kill the pneumococcus by producing granules that break down their cell walls. Meanwhile, macrophages engulf and directly kill these pathogens, are commonly known as phagocytosis. Third, pattern recognition receptors. These are receptors that are usually found on host cell surfaces designed to recognize pathogen-associated molecular patterns. There are two main types of receptors that participate in the host's immune responses to pneumococcus. First, toll-like receptors or TLR. There are currently 10 identified TLRs in humans. The main TLRs involved in pneumococcal infections are TLR1, TLR2, TLR4, TLR6, and TLR9, and are generally involved in cytokine production and recruitment of immune cells. Second, nucleotide binding oligomerization domain or NOD-like receptors or NLRs, which are intracellular proteins that can activate inflammasome formation, control inflammation, and stimulate nuclear factor kappa B. On the other hand, the adaptive immune system is a highly specific response that is enhanced by repeated exposure to a pathogen and develops for a few to several days. This type of immunity is subdivided into two arms. First, the antibody-mediated or humoral arm of immune response that function to block infections and eliminate the extracellular microbe immunity. This involves B cells as responding lymphocytes, and its effector mechanism comprises antibody secretions. During pneumococcal infections, IgA antibody is observed at high levels in mucosal areas of the nose and saliva, and is reviewed to be important for opsonizing S.pneumonia and promoting phagocytosis. Second, the cell-mediated arm of the immune response serves to activate macrophages to kill phagocytosed microbes and promotes the killing of infected cells and reservoirs of infection. This involves antigen-presenting cells or APCs paired with the major histocompatibility complex or MHC proteins, which both present antigens or peptides to T cells to stimulate a response. Specifically, activation of CD4 plus T cells and the differentiation of helper T cells stimulate a cellular-mediated immune response by producing cytokines that activate and recruit other immune cells such as macrophages during pneumococcal infection. Now we move on to the control, management, and prevention of S.pneumoniae. The most definitive preventive measure is immunization, and currently, there are two types of inactivated vaccinations that protect against S.pneumoniae. First, the pneumococcal conjugate vaccine or PCV13, which is a purified capsular polysaccharide designed to protect against 13 serotypes of S.pneumoniae that is covalently conjugated to a carrier protein, specifically the non-toxic recombinant of diphtheria toxin or CRM197. This vaccine elicits B and T cells to interact, where it provides long-lasting mucosal immunity and immunologic memory, proving its effectivity in children younger than 5, thus highly recommended. Second, the pneumococcal polysaccharide vaccine 23 or PPSV23, utilizing purified capsular polysaccharide antigens that induce protection against 23 serotypes of S.pneumoniae. The mechanism of this vaccine is a T-cell independent manner, where the plasma cells produce antibodies specific for the polysaccharide antigens upon recognition and maturation of the B cells. This vaccine is given routinely to adults who are 65 and older, as it only provides transient immunity lasting for 5 years. Hence, revaccination is necessary. The course treatment to outpatients of invasive pneumococcal disease by S.pneumoniae is typically prescribed with amoxicillin, with or without clavulanic acid, doxycycline, macrolide, or a quinolone. On the other hand, inpatients or those individuals who suffer severe pneumococcal pneumonia are introduced to intravenously treatment with ampicillin, ceftriaxone, or a penicillin, unless the patient is extremely ill, in which case vancomycin should be added. Supportive care may also be included when necessary, such as mechanical ventilation.